Today we are going to start looking at computed tomography or CT. This is also a unique modality in its way because it has many differences with conventional radiography. One of the differences is that if you look at the images created by conventional radiography, they are projected images. Images which are produced by conventional machines or X-ray, they are projected images. Just like if you have a torch in the night and then you torch at certain objects, you project that light at objects, you will see their shadows behind them. Get a torch, project that beam of light at objects, then the shadows of those objects, you will see them behind. Those you can see them as projected images of those objects. That's how conventional X-ray produces its images. Just a beam of X-rays falls on an object, and then a shadow of that object is casted on an image receptor. A shadow of that object is casted on an image receptor, like shadows of bones, shadows of what? Of tissues and what? They're just casted on an image receptor. That is a projected image. That means that if there is an image which is above, if there is an object which is above another, in the casted image, they are going to be overlapping over each other. It's like you will see them as one. Just like if we have an object here and we have another behind it. Let me say a beam of X-ray comes from this side. The final image which is created here will be an image of this. Will be on the image receptor. This is what you will see. If this is the image receptor, you will see an image of this, which is the big one. Whereas this one, the smaller one, will be also there within this, but you won't be able to visualize it well because it is actually overlapping onto the big object. So those are kind of projected images. Overlapping objects, you won't be able to see them differently or to differentiate them. In CT, the equipment produced does not display projected images. For it displays slices of images, slices of anatomy. The images are not projected, but they are displayed in form of slices, just like the way you have a bread at home that has slices. You have a whole bread and then you cut it into small slices. That's how CT produces images. So it produces slices of our anatomy as if it got like a knife and then started cutting slices of anatomy. The structures are not overlapping over each other. You see them independently in those slices. So that is one of the advantages it has. Producing images in slices brings out more detail than the details that can that you see in conventional radiographs. So the principles of operation of CT, I am sure you covered those principles in instrumentation and also the CT generations, including the first, second, third, fourth, fifth, sixth. Maybe you don't have the seventh yet, but it's also there. And there's also a newly approved CT. It was approved last year and it is in operation. I don't know whether it will be called the 8th generation, the photon counting CT. So those generations covered them in instrumentation. So the CT can be operated in two ways. We have what we call helical and also axial. First of all, you need to know that in CT we have an X-ray tube and a detector. But this X-ray tube and the detector, they must rotate around the patient to form these slices of images. The rotation can be continuous as the patient is moving. We call that helical scanning. Or the rotation can be in beats, whereby the X-ray tube and the detector rotate around the patient 180 degrees, 360 degrees, stops, and then the patient moves a bit, stops, then the tube and the detector moves again 360 degrees, stop, then the patient moves. So this is in beats. Rotation, stop, patient moves, stops, rotate again, stop, the patient moves, stops, like that. We call that axial scanning. The helical scanning is when the tube and detector are rotating continuously without stopping, and also the patient is moving continuously through the ball. We call that helical scanning. Like an example here, in this illustration, you see that we have a patient on the couch, and these round circles, they tell you, okay, they show you how the tube and the detector can rotate continuously while the patient is moving in the Z direction within the ball. Every complete rotation creates slices of anatomy. Every completion, the 360-degree completion of rotation creates slices of anatomy. The helical and the spiral, they are used interchangeably. There are some people that call it helical scanning or spiral scanning. These two words can be used interchangeably, but in the right English, they are different. As you can see in that top illustration, that these two are different. Spiral means that something, yes, is rotating, but it is the diameter of the circular path keeps on reducing until when it spirals into something or it converges into something. Whereas helical, the diameter of the circular path does not reduce. So there is no convergence. So when the system is started, the tube rotates continuously and the couch moves the patient through the plane of the rotating X-ray beam. Data are collected continuously and an image then can be reconstructed at any desired z-axis or z-axis position of the patient, as we are going to see. So I need to tell you this, that CT is a mathematical equipment. Everything associated with this equipment is mathematics. Even how the images are reconstructed and displayed on the computer, it is all mathematics that plays the biggest part. There's no mathematics in conventional radiography. Nothing like mathematics there. But in CT, every problem associated with it is a mathematical problem. The software is all mathematics. So, as the patient is moving through the bore of this machine, the slices are being collected, or information is being collected to get the slices of this anatomy. But because the patient is moving and also the X-ray tube is rotating, there are some bits of anatomy that can be skipped without scanning them. The patient is moving, at the same time the CT is rotating. There are some bits within the anatomy that may not be captured during scanning, during this scanning. Those bits of anatomy can be reproduced mathematically. That information that is not in the scan data can be estimated using mathematics. We call that interpolation or extrapolation. Using interpolation algorithms, those are mathematical equations. If you remember in your mathematics, whether O or A level, we used to do interpolation. Like you can have two known values, like for example, this one and there and that one. If you have two known values, if for example, if you have this graph, if you have these two known values, it becomes very easy to calculate the unknown value in between the two. It becomes very easy to calculate the unknown value in between the two. We call that interpolation. Or it becomes very easy to calculate an unknown value outside the two, which we call the extrapolation. So these algorithms in CT can be used to estimate the information in between maybe the two slices. To estimate the information in between the two slices. For example, if this was the patient and we get a slice here, and maybe the speed at which the coach was moving, then we got another slice just besides the other with some missing information in between. There's some missing information in between there. That information can be estimated using information of this slice and this slice to estimate what is missing in between them. We call that interpolation. If it's not done, the images created by the CT in other planes, CT gets images in axial planes or in the transverse plane. But we can do what we call reconstruction and get images in other planes, like the sagittal and the coronal. The CT cannot acquire data in sagittal, cannot acquire data in coronal. It only acquires data in axial planes. After acquiring that data in axial planes, the software of the CT can reconstruct or can use this data to reconstruct images in other planes, like the sagittal and the coronal. If interpolation is not done well, the images, especially in the sagittal and the coronal, will be of poor quality. If interpolation is not done well by this software. Okay. So during helical CT, image data are received continuously. During helical, that is, the tube and the detector are moving continuously, and the patient is also moving continuously through the bore. The data is received continuously. When an image is reconstructed, for example, in B, you can see an image has been reconstructed. The plane of the image does not contain enough data for reconstruction. The plane of the image does not contain enough data for reconstruction. So data in that plane must be estimated by interpolation. When we have some missing information, for example, in the previous thing that I've drawn for you, we have some missing information. Interpolation can be done such that these slices can have enough information to display. Data interpolation is performed by a special computer program called interpolation algorithms. The plane of the reconstructed image was interpolated from data acquired one revolution apart. Like if you get a slice here at a certain position, one revolution apart, you get another slice. So there could be some missing information between the two slices. So interpolation can be done such that we can get enough information for both of the two slices. When these images are formatted into sagittal and the coronal views, prominent blurring can occur compared with conventional CT reformatted images. If interpolation is not done and you reconstruct images in coronal and the sagittal, there will be prominent blurring of these images. The solution to the blurring problem is interpolation of values separated by 180 degrees, that is half a revolution of the X-ray tube. This results in improved Z-axis resolution. The resolution in the Z-axis, you can only see it when you reconstruct images in coronal and sagittal, and greatly improved reformatted sagittal and coronal views. Okay, that is interpolation. You have slices, the CT creates slices of anatomy, but the slices may not have enough information because maybe during scanning there is some data that is missing. In order to get that data which is missing, interpolation must be done. After interpolation has been done, then the slices have enough information to display. And this reduces blurring if those images are reconstructed in other views, like the sagittal and the coronal. A pitch in CT, in layman, compares rotation of the tube and the detector and the speed of movement of the patient's couch. Just like what we have been looking at, the tube and detector are moving continuously around the patient, and the patient is on the table also making a motion through the bone. Sometimes the table movement may be at a higher speed if you compare it with the tube and detector rotation. Sometimes the table movement may be faster when you compare it with the tube and the detector movement or rotation around the patient. Sometimes the speed of the table is very low compared to the tube and the detector rotation, and sometimes the table speed and the tube rotation can be comparable. What does that mean? If the speed of the table is so high compared to the speed at which the tube and detector complete the 360-degree rotation, it means that chances are there that there will be some missing tissues that are not scanned. There will be tissues that are not going to be interrogated by the X-ray beam. If the table is moving so fast compared the table to the speed movement, it means that as the tube and detector are rotating, the table is moving this side. If the tube and detector are rotating, it means that if this is the patient is moving very fast compared to the tube and the detector rotation, it means that a slice can be captured here, but because the table is so fast, there will be a larger volume of tissue missed, and then another slice is created here. Then a large volume of tissue is missed, and then another slice is created here. When the table is moving, if the coach speed is comparable to the tube and the detector rotation, it means that they are almost the detector and the tube rotation and also the table speed, they match each other, such that if a slice is created here, the second slice shares a boundary with the first, and then it is created here. There is not any missing tissue. And then the third slice shares a boundary with the second, and then it is created here. So this is the first slice, second slice, third slice. they share boundaries. So they are skin to skin. There's not any missing tissue. It means that the table movement and the X-ray tube and the detector rotation are almost comparable. They match each other. And if the table is moving at a very slow speed compared to the tube and the detector rotation, if a slice is created here like this, another slice can overlap onto the other and then is created here. So the tissue in between has been exposed twice in this case. The tissue that both slices are sharing is exposed more than once. If we are to create a third slice, then the third slice can begin from here and then end here. So the third slice, part of it is in the second slice. So this means that the table is moving very, very slow. This kind of pitch increases the patient's dose because there are some tissues which are going to be exposed more than once. The advantage it has a very good spatial and contrast resolution. A very small pitch, this is a very small pitch, improves spatial resolution more. And this pitch is normally applied when we are doing CT scans of the head, because inside the head, the brain, and also some other small parts in the bones, my anatomy is limited. We have some small parts within the head that needs a lot of spatial resolution for them to be visualized very well. Like the brain needs a lot of spatial resolution to be well visualized. That pitch is very important in head CTs. Though it increases the patient's radiation dose because some tissues are exposed more than once. This one, where slices are skin to skin, is important in other parts of the body, like maybe chest or abdomen and other parts. This one is okay. Okay. Then the pitch, whereby some volumes of tissues are skipped without imaging them. It is very important when it comes to uncooperative patients, that you want to capture this scan or these images at a very high speed and in the very shortest time possible. You want to capture them in the very shortest time possible before even the patient thinks about making any movement. For example, the patients that have a problem with their brains, they are making movements everywhere. All patients who are in too much pain and they cannot be in one position for a long time. So you need to capture images very fast without the patient thinks about making any movement. So this one, you can scan a very big a very big length of the anatomy or a very big volume of the anatomy in the shortest time possible. This one, skin to skin, not very short time, but it is also important. Then this one, with a very small pitch. That one, it needs you when you need to use it when you want very high resolution images, but it takes time to complete a scan. It takes time to complete a scan and it increases patient's radiation dose. So this is a pitch less than 1. This pitch is equal to 1 here, and this pitch is greater than 1. Interpolation algorithms allow imaging at a pitch greater than 1. Remember, interpolation estimates information that is in between the slices, the information of the tissues that have been missed. So interpolation, with a pitch greater than 1, interpolation can try to estimate information between the slices. But if the slice gap, if those gaps are big, then an interpolation algorithms breaks down. It may not accurately estimate the information in between those slices. The pitch is a relationship between the patient coach movement and the X-ray beam width. Pitch is a ratio such as 0.5 to 1, 0.5 to 1, 1.0 to 1, and 1.5 to 1. 0.5 divided by 1 is 0.5. So that pitch is less than 1. This pitch is less than 1 applied in head CTs. This pitch is 1 applied in other parts. This pitch is greater than 1 and this one is greater than 1. This one is basically for anticooperative patients, or when you are like, the chest wall is moving very fast. When you inhale and exhale, it's moving up and down. So it may also require a pitch which is somewhat greater than 1, such that you capture these images very fast without the chest moving up and down very many times during that scan. So a pitch of less than 1, that is 0.5, results in overlapping images and high patient radiation dose. A pitch of 2 to 1, that is a pitch of 2, results in extended imaging and reduced patient radiation dose. Okay, this is mathematics. You can leave that statement. Pitch that you can use, and because it limits you within the, on that in that pitch, okay, it only gives you pitch that at least it can do the interpolation very well. But of course, as I said, interpolation is just an estimate. It is not giving you a completely inaccurate thing. It can do the interpolation, but again, the information won't be as accurate as if the pitch was 1 or even less than 1. So it limits you on how far you can go when it comes to the pitch. So it can only gives you pitch where interpolation can be done. Pitch, as the pitch increases above 1, the volume of the tissue that is imaged at a given time increases also. In this, if you use a pitch of maybe greater than 1, and you are to scan from the beginning of the chest to the end of the pelvis, you can acquire all that volume within a very short time possible. From the chest to the pelvis, you can acquire all that volume of the chest together with the abdomen and the pelvis within a very short time. Whereas if you are to use a pitch of less than 1, it's like 0.5, it will take this system some time to complete all this scan. From the beginning of the chest, you do the abdomen and the pelvis all together. It will take some time. And the more time, remember the slices are overlapping each other, some tissues are exposed more than once, and also the time taken, the patient radiation dose is going to be high. So with a pitch, with increase in pitch, which increases the volume of the tissue imaged, this is an advantage of multi-slice helical CT, the ability to image a large volume of the tissue in a single breath hold. Just like, you know, when they are going to scan a patient, they tell the patient to breathe in and hold their breath, especially when you're going to take chest exams or even abdomen. Breathe in and hold your breath. The patient has to be in a position to breathe in and hold the breath until when the entire examination is complete. Forget about this chest X-ray, whereby just milliseconds the image is taken. CT takes seconds. Can even take like 15 seconds just scanning to complete the entire length that you have commanded it to scan. So with a pitch of greater than 1, and also with the introduction of the multi-slice CT, multi-slice helical CTs, a patient can be scanned from the head to the top in just a single breath hold. In just a single breath hold, you can get the images of the entire anatomy within seconds. So it is particularly helpful in CT angiography, that pitch of greater than 1. It is very helpful in CT angiography because you want to capture contrast when it is still in circulation at a very high speed. It's also in radiotherapy treatment planning, CTs that CT images we need for treatment planning radiotherapy can be captured at a pitch greater than 1 because we don't need images that are diagnostic. In treatment planning, we don't need really diagnostic images. We want just images for planning. And imaging of uncooperative patients, you can use a pitch of greater than 1. With first multi-slice helical CT, whole body imaging is now possible within a single breath hold. That is what I've been talking about. With the first multi-slice helical CT, whole body imaging is now possible within a single breath hold. I don't know whether you understand when I say multi-slice. Do you understand that?
Yes, sir. Many slices.
Okay. Like, it means like in a single rotation, the CT can get a number of slices. In just a single rotation, like 360-degree rotation of the X-ray tube and the detector, you can get a number of slices of anatomy. If it was like a single slice CT, that means on every rotation, we are just getting a single slice of anatomy. With multi-slice, in a single rotation, you get slices of anatomy. So that's why these days we have CTs like a CT can be called, maybe this is a 16 slice CT, the other one is a 32 slice CT, 64 slice CT, maybe 128, 256, 320 slices. What does that mean? If it is like, for example, a 250, let me use 128 slice CT, it means that it is possible that on a single rotation, a CT can create one. So here we have 16 rows of detectors, meaning that on every rotation, every row can create its own anatomy. I mean, can create its own slice of anatomy. Is that well understood?
Yes, sir.
Yes, sir.
Okay. So if it is like a 256 slice CT, a 256 slice CT in just a single rotation, you can have all the slices of the heart, because the size of that detector is comparable to the size of the heart. So in just a single rotation like this, you have all the slices of the heart. You don't need to even, I mean, the CT does not even need to rotate another time if you are interested in the heart. Just a single rotation, you have all the slices of the heart. But a single slice CT, it has to rotate a number of times to have all the slices of the heart. So that means that if you command your system to reconstruct, for example, if the row of the detector, if a single row has a thickness of 0.5 millimeters, if a single row has a thickness of 0.5 millimeters, and each row is creating its own slice, that means slices, the thickness of those slices will also be 0.5 millimeters each. But we normally don't want slices of very thin thickness. We need, because the smaller, the thinner the slice, yes, the better the spatial resolution, but the poorer the contrast, and the more noise in that slice. So we normally don't allow each row to create its own slice. During reconstruction, we can merge these slices to get bigger slices. For example, we can use a 16 slice CT, like for example, this one is a 16 slice CT because there are 16 rows of detectors. We can use 16 slice CT and create only 8 images or 8 slices. That means that the system is using information from two detectors or from two rows to create just a single slice. For example, it can take information from these two, creates one slice, these two creates one slice. So in the end, you're going to have 8 slices, but produced by a 16 slice CT. Or you can even increase the thickness to maybe you can get 4. You get information from 4 detectors, you create one slice. 4 detectors, you create one slice. And then in the end, you're having 4 slices, but produced by a 16 slice CT. We call this collimation in CT. You can change this. If it is a 16 slice, when you go to collimation, you see different combinations. 16 by maybe 0.5, 16 by 1.25, 16 by maybe 2.25. So you will have different combinations. That one will tell you, that one will be actually telling you what kind of thickness that you're going to get at each slice in the end. Members, is that okay?
Yes, sir, it's okay.
Okay. Right, let's proceed. Usually pitch for multi-slice helical CT is 1 because multiple slices are obtained on the z-axis location, and reconstruction width can be selected after imaging. Reconstruction width can be selected after imaging. These overlapping images are unnecessary, like the pitch of less than 1, they are unnecessary in most of the scans, but it is necessary when it comes to head CTs. Because of multi-slice capability, most slices are acquired per unit time. This results in much larger volume of imaged tissue. Unfortunately, when the pitch exceeds approximately 1, when the pitch exceeds 1, the z-axis resolution is reduced. Remember, there is some information you're skipping with a pitch greater than 1. So that means that the resolution, the z-axis, especially when you are reconstructing images in the coronal and sagittal views, it will reduce. It will reduce. We have what we call the sensitivity profile. This one assumes that, okay, we normally assume that a CT, I mean, when the beam is collimated, it only covers where it wants that slice from. Like it's as if you're going to have a perfect, we are going to have a beam passing through a perfect dimension of the anatomy. But that is not true. The beam diverges a bit, and so we will realize that instead of having a perfect slice like this, we have something of this kind because the beam has that kind of profile in it. So if the slices, if the slices are so like close to each other, this sensitivity profile will keep on overlapping over each other like that. So if you have a sensitivity profile like this, we can use its full width at half maxima to get to know the size of the slice that it is actually representing. Full width at half maxima. Okay, in the middle of this sensitivity profile, we can estimate the slice of the beam width that actually interrogated that section. This is actually a job of a medical physicist when we are doing quality assurance. So that's why I don't want to go into the details of it on how it is done because it is way beyond your scope, but we can leave it at that. Image characteristics. Image obtained in CT is different from that obtained in conventional radiography. That is what I was talking about in the beginning. It is created from data received and is not a projected image. Images produced in CTs are not projected images. In radiography, X-rays form an image directly on the image receptor. The images are just projected on the image receptor, just like a torch. When you project it on objects, those objects are going to cast shadows behind them. With the CT imaging systems, the X-rays form a stored electronic image that is displayed as a matrix of intensities. So let's see that. Let's see what it means. When a radiation beam from the CT goes through the patient's body, the detectors at the end, they acquire what we call attenuation data. They acquire what we call attenuation data. What does this all mean? If you have a patient here, and this is maybe, we are going to assume a single photon ray. This is going to come, okay, let's assume a single beam, like a pencil beam of intensities. It is going to pass through a patient. A CT, in fact, has two detectors. It has the pre-patient detector, which is located in the gantry just below the X-ray tube, and also the post-patient detectors, which we have just looked at. Those detectors which acquire the data, the ones that have rows, those are called the post-patient detectors. Now, the pre-patient detector measures intensity of these X-rays, measures the original intensity of these X-rays as I naught. But when the beam goes through the patient, there will be some attenuation of this beam. You don't expect the same intensity to go through the patient. So the post-patient detectors, they measure I. They measure the final intensity falling on them. And then they feed those values into this equation, I is equal to I naught exponential minus mu x. This equation is very common to people who have ever done mathematics. It is an exponential equation where I is the final intensity measured, I naught is the initial intensity measured, this mu is the attenuation coefficient. It is specific to different tissues. It tells us how much of the beam has been attenuated as it is going through. And also X is the thickness, for example, of this patient. But when this beam is going through the patient, it is going to go through different structures. We are not, like, the structures in the body are not similar. they differ in the way they attenuate. So if I am to exaggerate it more, I'm going to draw a single line of matrices. I mean a single line of pixels where this ray is passing. So what the system does is that where this ray of intensities is passing, it is going to divide that path into smaller pixels. Because we have different structures all over this path. We have different structures all over this path. And these structures attenuate this beam differently. So the final attenuation coefficient mu is just a summation of these attenuation coefficients in different pixels, because each pixel is representing something about these different organs. So it will be a summation of mu1 plus mu2 plus mu n. They can be many, plus mu n until mu n. So you realize that the final equation is going to be I is equal to I naught exponential negative mu1 plus mu2 plus until mu n in bracket x. X will be the thickness of this patient. Now, this is just a single ray of intensities. There can be thousands of rays of these intensities. They can be thousands. And remember also, the X-ray tube and the detector, they must rotate around the patient, meaning that we are going to get other rays like in those positions like that, many of them. And all these equations must be calculated by a CT. The CT can get a volume of data that it has to calculate in the end. These are just simple equations which I have shown you, showed you. But actually, these equations can be solved by what we call fast Fourier transform equations. To be very accurate, the CT uses fast Fourier transform equations to calculate, because if we have like this is our anatomy, this anatomy is going to be divided into a number of pixels. It's going to be divided into a number of pixels. They can be thousands of pixels, hundreds of thousands of pixels. So it has to do all the mathematics to calculate the attenuation coefficient for every individual pixel. To calculate the attenuation coefficient for every individual pixel. Because every pixel must have a different value, because every pixel is representing something different. Okay, maybe if these pixels are like, for example, pixels which are representing a liver, they can be of the same number because all of them are representing a liver. Of course, when they are calculated, the number carried by those pixels will almost be the same. But if other pixels are giving out information for the kidney, they are carrying a different number. Now, if we are to present a slice has hundreds of thousands of pixels. For example, if you have a matrix of 512 by 512, it means that you are going to have a matrix of 262,000 pixels. This image is going to be displayed by 262,000 pixels. This implies that to get information for each and every pixel, this CT system must calculate equations equal to 262,000 in just seconds. In just seconds to give just a single slice. Now just imagine when it is to create maybe 32 slices. So 32 times 262,000, those are the equations that it has to calculate to give you slices in just seconds. So image reconstruction in CT is a mathematics, not projected images. It is just mathematics. Fast Fourier transform equations are not only for changing information from one form to another. And I know why you're going, changing from maybe spatial location domain to maybe a frequency domain. Not only that, but also to do these calculations, you can use the same. You can use the same equations. The system can use the same equations. Okay. So after calculating the attenuation coefficient for every pixel, then it has to use those attenuation coefficients for every pixel to calculate the CT number or the Hauss field unit for every pixel. Because it is not going to display attenuation coefficients, it displays CT numbers. So it will use the attenuation coefficient for every pixel to calculate its corresponding CT number or Hauss field unit, as we are going to see. Okay. The image matrix tells us the number of pixels that are displayed. I mean, the number of pixels that are displaying an image. The diameter of image reconstruction is called the field of view. The diameter or the field which is actually giving you an image on the display is a field of view. And it is you, a radiographer, that can determine the field of view. If you want a small field of view, you can make it small and truncate most of the anatomy such that you can, maybe if you are interested in displaying only a kidney, You can use a small field of view during scanning, and then the system will truncate all other information, and then it only gives you the kidding or that area which has a kidding on your display. That will be your field of view. You can limit it. That means if a matrix is 512 by 512, instead of using it to display the entire like anatomy or the entire slice where the kidding is, you can use the same matrix and display only the kidding by limiting the field of view to only the kidding. When the field of view is increased for a field matrix, for a fixed matrix, the size of each pixel is going to also increase. That deteriorates image quality.
Sir, pardon on that. I didn't get that properly.
Okay. Here, what I mean, if you have a matrix of 512 by 512, that means you have 512 columns, and by 512 rows, you have about 262,000 pixels. If your matrix is like that, and it is maybe displaying if this is your anatomy and it is displaying like all this section of anatomy, but then you want to increase this field of view. Remember, when you increase field of view, you don't change anything on the matrix. You just want to enlarge its display. The matrix size the matrix number will not change, but in order to fill up all this display, the wider field of view, the matrix size has to increase. And if the matrix size increase, the pixel size has to increase. And if the pixel size increases, it deteriorates the image quality. When the matrix size is increased, it means that you're increasing the number of pixels. Maybe from 512 by 512 to 1024 by 1024. And for a fixed field of view, that means that the pixel size must reduce. You have this is your field of view, fixed one, and at first you are using 512 by 512. If you want your field of view to remain fixed, and then you increase the matrix size, the matrix size to 1028 by 1028, 1024 by 1024. Of course, to fit them in the same fixed field of view, their size must reduce. The size of the matrix must reduce by a half to fit. 512 plus 512 is 1024. So, if you want to double the matrix size for the fixed field of view, each pixel must reduce by 1/2 to accommodate all of them. That improves spatial resolution. Remember, the smaller the size of the pixel, the better the spatial resolution. A pixel is a two-dimensional part of an image. It's just a two-dimensional image. Just a single pixel is a two-dimensional image. But a pixel also has a thickness because a slice of an image has thickness. If the thickness of a slice is 3 millimeters, also the thickness of the pixel is 3 millimeters. If this is our slice in 3 dimensions, I'm drawing the slice in 3 dimensions. This is a slice. A pixel is this two-dimensional, this square you're seeing here is a pixel. But because a slice has a thickness, also the pixel has a thickness. And if you want to, the name given to it with the thickness inclusive is what we call a voxel. So a pixel, that is a part of an image in 2 dimensions. A voxel, the same part of an image in 3 dimensions. So because you're bringing in the thickness also. Now, why is it that with smaller thicknesses, you have you have a lot of noise in the image? It gives us a better spatial resolution, but you have a lot of noise. Smaller thicknesses mean that they have few photons of X-rays in them. The more you reduce this thickness to be smaller, that means that even the photons that were used to create this slice thickness have also reduced in number. The photons of X-rays which were used to produce this thickness have also reduced in number. And the fewer the photons in the slice, the more the noise in that slice. In order to, if you want to create very thin slices with good spatial resolution okay, with less noise, you must increase on the technique. That is, increase in the MA, such that you can have a very big, you can have a large intensity going through that thin slice. Smaller slices have better spatial resolution, but their problem is noise. In order to counter that noise, if you're going to use smaller slices to improve spatial resolution, increase also on the technique. But if you're not interested in smaller slices, in spatial resolution that much, you can use thicker slices, because the thicker the slice, the more photons in it, the less the noise. Of course, there will be some reduction in spatial resolution, but there will be somewhat a better contrast resolution. Members, we are together. I know this physics is kind of complicated, but I think you're getting something, right?
Yes, sir. May I repeat it?
Okay, let us look at CT numbers. These CT numbers are very, very important. They are very important. Remember, I've just told you that the system acquires attenuation data, calculates attenuation coefficient for each and every pixel, and then uses those attenuation coefficients for each pixel to calculate their corresponding CT numbers. It is the CT numbers that we are most interested in. It is the CT numbers that most of the radiologists use to make their diagnosis clear. Each pixel displayed has a level of brightness, and this level of brightness depends on the CT number it is carrying. These levels correspond to a range of CT numbers from negative 1,000 to positive 3,000. Sometimes the CTs can have CT numbers ranging from negative 1,000 to positive 1,000, whereby the negative 1,000 corresponds to air and the positive 3,000 corresponds to dense bone. So different tissues in the body have different CT numbers or CT number ranges. And for example, in this on the right, you're seeing different tissues with their specific CT numbers. Of course, you cannot get these numbers specific. They